one of the most cyanotic congenital heart disease. No sex difference between multiple sexes are affected equally, and may be associated with another genetic disorder such as Down syndrome, George, and vectoral or charge association. What about the epidemiology of tetralogy of Fallot? Tetralogy of Fallot was occurred due to anterior displacement of the aortopulmonary septum during the neonatal period, leading to the decrease or narrowing of the right ventricular outflow, which created of ULSD. Due to increasing pressure or due to right ventricular outflow obstruction, leading to increased pressure in the right ventricle and creating right ventricular hypertrophy. So there are risk factors including polynutritional, sick, viral illness, or family history or genetic risk, which as told before. The four hallmark for feature of disease malformation is pulmonary or pulmonary stenosis. The pulmonary stenosis of right ventricular outflow may occur at a multiple level, may be at the infundibular part or abnormality in the valve or the proximal part of the pulmonary artery, ventricular septal defect, maybe perimembranous or minor alignment USD, which allow the right to left the chunk from right to left chunk due to decrease pressure in the right ventricle. Also, overriding of aorta and right ventricular hypertrophy. It's commonly maybe present in neonatal period. This is associated with severe form and may be diagnosed antenatal by fetal echo. About the anatomical spectrum of tetralogy of Fallot, it comprises a large spectrum of anatomical variation. Maybe VSD with limited aortic overriding and mild form of pulmonary obstruction at the 1 to the critical form with VSD with pulmonary stenosis. So, some surgeon, congenital heart surgeon society, is recommended to classify the TOF into 3 categories. The first one, tetralogy of Fallot with varying degree of pulmonary stenosis, or tetralogy of Fallot with atrioventricular septal defect, or with absent pulmonary valve. About 20% of patients with the TOF also may have pulmonary atresia. So some US centers render VSD with pulmonary atresia as the fourth category of the variation or spectrum of tetralogy of Fallot. Anatomical variation may be including the absence of a native pulmonary artery, pulmonary valve, or presence of a measure of Mercap's as a main source of pulmonary blood flow. May be associated with many anomalies. This anomaly, including stenosis of left pulmonary artery, right side aortic arch, bicuspid pulmonary valve, AZ, persistent left spirulina cable, or coronary artery abnormality. Or pathophysiology, pulmonary stenosis, also creating a concentric right ventricular hypertrophy without increase in right ventricular pressure. By the time when the right ventricular pressure equal to the left ventricular pressure, they permit a right to left chunk to decompress the right ventricle. Once the right ventricle and left ventricular pressure equal with severe pulmonary stenosis, this will reduce the flow through the pulmonary artery, so the cyanosis increase. So the more severe pulmonary stenosis, less your flow in your pulmonary artery, and the bigger your right to left chunk, the more cyanosis. VSD in your TOF, or you are large enough to permit right to left chunk. So the congestive heart failure is not occur in this pathology. Pathophysiology, Increasing your right ventricular pressure may be due to increase the pressure of the spasm of the right ventricular outflow due to many reasons. Sometimes you will decrease for any reason that you need to decrease systemic venous return, leading to hypoxia, hypercapnia, and metabolic acidosis, and this will lead to increase systemic pressure. That's why your right ventricular charm is increased. This is what you are saying. The important feature to determine the hemodynamic consequence of your tetralogy of fellow is the size of your VSD, severity of right ventricular outflow, drug obstruction, or the level of systemic venous return. About the clinical presentation, has a variable, tetralogy of fellow have a variable and dependent on your right ventricular outflow, may be present with cyanosis, failure to try, cyanotic spell, or fatigability according to the degree. The clinical presentation may be simplified in three categories. Maybe mild fault if it's associated with a mild pulmonary stenosis, or maybe cyanotic tough with classic with varying degree, or extremely tough, maybe present easy. So there's two ends for the presentation of the tetralogy of fellow. What's apart from paroxysmal cyanotic attack, this is a hormone for tetralogy of fellow, occurred during the first 2 years of the life, and mainly present within 4 to 6 months of age.
Time, دليل زهرة تاني.
مش تقدر تحسب الوقت.
حولتش الصورة
So it's characterized by dyspnea, gasping respiration, and you are sinful, and maybe you are loss of conscious, or even you are convulsion. Deep cyanosis will decrease in the intensity of murmur, or then you are metabolic acidosis.
هل تصف الجراية زهرة؟
However, a small group of neonatal and infant may accept a profound hypoxia, especially if has that severe pulmonary stenosis or pulmonary atresia. So it's dependent. That's why PDA patency is mandatory for this patient. This is a trigger for hypercyanotic episode, systemic stimuli, withholding faltata and Hahouma, crying, exercise, and hypoxia, vasodilator, and all sudden decrease in systemic venous return or symptomatic drug. Physical examination varying degree of cyanosis, clapping, to proportional to the level of cyanosis, bulging pericardium due to right ventricular hypertrophy, asystolically trend may be present in the left sternal border, and left sternal parasternal heel with allowed secondary heart sound, which is single, with ejection systolically murmur may be present, or continuous murmur if the PDA is present. About the diagnostic modality for tetralogy of fellow, besides bedside or the clinical examination, sometimes the pulse meter is very mandate, especially you are immunate to select if the patient is not to cry or not, and to measure your oxygen saturation, and lab investigation and polycythemia in your CBC, and then you will start with your further evaluation by your X-ray, ECG, echocardiography, CT, MRI, and CAT mainly. CT, what's the finding in the chest X-ray? Typically finding abnormal size of the heart with upturning of the apex, that's called your shaped heart, with decrease in pulmonary vascular marking. ECG is a sign of right ventricular.
2 minutes. 2 minutes.
Okay. The echo is the gold standard for the diagnosis of tetralogy of fellow. This is one non-invasive modality to clarify the severity of right ventricular hypertrophy, location and the number of VSD, and associated anomaly, and the size of the aortic arch or coronary variant. CT, to do a CT and MRI and catheterization يلواني to dilate anatomical or pressure or hemodynamic measurement of the patient. The management of silent spell may be supportive or specific. Overall management may include medical or surgical management. Medical, especially in neonates, may need prostaglandin to maintain the patency of BDA, separating position, beta blocker, mild and other children, morphine, and omasamine for value expansion. It's a surgical, including propeltive or defective correction.
نعطوك 1 minute. لا كان بغازي عملوا احسن دقيقة.
Session 1, hall 1, hall 2, hall 3, hall 4. هي hall 1 مش امس قدام رئيس الوزراء ما امس الكلام. بدي محتخر او فيها تقنية كويسة. هكذا دوت. المشكلة في الدين
The last slide. So one your conclusion is have a different or everyone representation and have a different modality for the diagnosis and maybe associated with genetically disease such as Down syndrome or Jadour syndrome. Thanks for attention.
شكرا دكتورة سليمة for nice presentation and the discussion later on. Next speaker.
Can I take 2 or 3 questions?
While we are waiting for technical issues, sorry about delay in the session. We offer a question if there is any question before we get the next speaker. Thank you, Dr. Salima, about your presentation, nice presentation. And sorry about the technical issues throughout your presentation. We can offer a few questions from the audience. Anyone come to the floor and ask any question? More than happy to take 1 or 2 questions before we move on to the next speaker. And the next speaker هيكون حتى online. I think Dr. Novick has online too. Dr. Huda Shashari.
I want to just make a comment. It was a nice presentation. I come from US and I follow patients with the tetralogy of Fallot and that they come in adulthood, and I was just discussing it with Dr. Bassett. So I wanted to add that as they become adults, we have to concentrate on the pulmonary insufficiency and the RV dysfunction, and the other issue that can happen over the long run is ventricular arrhythmias. So I have a few patients that require transcardiac pulmonary replacement, as well as you know, as an interventional cardiologist. So as an adult, we have to do advanced imaging, cardiac MRI or cardiac CT. MRI is better to evaluate the RV volume. We usually refer them for intervention when the RV volume is more than 150 meter square, and to save, of course, the RV from the RV failure and dysfunction. I have another patient that I have been following, Christopher. He developed arrhythmia and he had syncope on exertion. So I placed an event monitor on him. And and he had very episodes of rounds of ventricular tachycardia. So I referred him to EP, and they recommended to place an ICD. They did EP study, and they found scarring, of course. He had an MRI as well. He refused in the beginning to have an ICD. So I told him, I tried to convince him that there's a risk of sudden cardiac there. So I asked him to have a second opinion and presented his case at the adult congenital program at Cincinnati Children. And they agreed that this case is an indication for ICD, and he ended up having an ICD, and I still see him in my office. He's in his late 20s now. He has 2 kids and he's very happy, and he's doing much better. So these are my 2 points about the tetralogy of Fallot in adults.
Thank you, Dr. Rahouma, about a nice question. In my talk later on today about transpulmonary valve implantation, we're going through that issues. It's very nice that you are alerting the audience about the service. Dr. Hanifa yesterday, she introduced about transitional care for adult congenital cardiology, which is very, very important missing service in the country. We hope in the near future we're going to start the service in the adult congenital, and we have a new program in Libya to introduce the transpulmonary valve implantation. There is a huge number of cases, as you know, who underwent surgical correction for phallic tetralogy. Now they live, and they presented with right ventricular failure and dysfunction and arrhythmia. As you see, there's a criteria indication by European, by American Society of Cardiology, who's indicated for transplant. In the old days, they have surgical intervention, and most of the countries nowadays, and over the last 2 decades, they introduced the service. The service, unfortunately, in Libya, get delayed because, like TAVI in the adult, which is just started in Libya, we hope we have a plan that we're going to introduce the service of the transpulmonary valve implantation. And this is from this conference. I hope that our colleague surgeon, I spoke to Dr. Hasan a few weeks ago, and we're trying to collect the cases who's going, and I'm talking to my colleague who's attending. We are collecting the cases who had truncus arteriosus repair, who had transposition with VSD and have conduit, Arastellis, whatever the procedure that indicate, which is the majority is the phallic tetralogy, I know, but they present with even the pulmonary valve stenosis who had valvotomy, and they present with pulmonary care. As you said, nowadays the non-imaging consultant, I think your colleague Dr. Zohra Shibani, she is also in contribution with the other congenital, and they have assessed those patients, and there is a criteria to go through, and now with the service of the CT and MRI facilities, those patients, as you said, right ventricular end-diastolic volume over 150 or 170 are indicated for transplant. So there's this service is not available in the country. So we have to go as a whole program. We cannot just start intervention when we don't have supporting imaging, which is equivalent to the cardiac catheter in planning ahead this service. So we're going to work together with the surgeon, with the team, with the imaging consultant, with the CT and MRI service to get the service. I'm not going to take too long. We can discuss that later. If there's any question, otherwise we have to move to the next speaker. Ready? Dr. Mohammed, تفضل. أنت خش.
هي مشكلة الفولو بالتنويج، بس في ميزة في الكاردياك سيرجري. ميزة you take your patient from the day you operated them until he dies. فبالتالي يعني he's with you. I remember 2 months ago I saw a patient which I operated on in 89, fellow. Now she is 24, she get married, she's pregnant, she was pregnant and she had a child with her. So they do it. They have the operation early. and they can survive, and they can even conceive and get married and bring children. I think Dr. Hasan has the largest record of congenital surgery in Libya, because he kept his record from the day one until now, and also in the Europe, a good record of those patients. So it can be done if one of the young people will take this over. We can have a good record of those patients, and then it is time to establish where they've grown up congenital, and through that we can proceed.
One comment.
حسن أنا عبد الحسن أنا يا أبا
طيب يا حسن.
والله مش الكلمة
لا الثاني مازال مش ردي.
I'm not sure how many patients need pulmonary valve replacement because we don't have the MRI facility to really measure the RV volume, as Dr. Huda was saying. We are just going on by clinical. I have done, I think, 2 or 3 pulmonary valve replacements post-talk. I can't give you the exact number of talk that we did, but I think once we get, as Dr. Salem said, we really need the MRI facility to really measure these post-operative cases and then go by the scientific method that who needs this pulmonary implants and who really don't. But we're just doing, as I said, by clinical and by eyeballing, CT, echo. But amazingly, those who we operated on had quite huge RV, and post-operatively they really came down and symptomatically they were really relieved. So I'm really amazed on the RV remodeling, yeah.
But which type of valve يعني you put?
We put هذا اسمها الزينوغراف. xenograph around 12 tissue valve,
The center I work with in Indianapolis, the surgeons are trying to do pulmonary saving procedure, like they do bronchotomy and they try to save the
You preserve the pulmonary valve.
That's what we're doing. We're trying to preserve as much as possible.
They do accept, like, they will come back for follow-up with mild
gradient, yeah, rather than up here. Yeah.
We try to avoid too surgical. يعني this is an open heart surgery. He had already a surgery. Nowadays you cannot offer him another surgery. بعدين حتى لو درت tissue valve or trifecta, whatever the other advanced, you have transcatheter implantation, successful rate, thousands of or 100,000 of cases reported worldwide. So why we don't move to that side? I mean, I will really, دكتور عطاف عندك سؤال.
إجابة على السؤال بتاع حضرتك why do prefer transcatheter implantation rather than surgical. هو الأنصر إنه long term follow up يعني for the surgical implantation whatever mechanical or prosthetic valve position, we have 30-40 years follow up and know well how this valve is known and the long term follow up. But for the melody or for the transvalve or the transcatheter implantation, still we are lacking the long term follow up as well as degeneration of this valve. What it will do after 20 years, for example, no one knows.
They're already 20 years already.
But in a large...
عطي سؤال ترد عليك يا سؤال.
افتح الواحد المايك مش مفتوح. افتحي المايك. لا ما دفعش
I think this would be a completely different talk, so maybe we can leave the discussion when Dr. Salem gives his talk. And within a trifecta valve, there is no ideal pulmonary valve replacement. We don't put mechanical valves in the pulmonary area. You put xenografts and tissue valves, which thrombose, calcify, and become regurgitant, especially in the young group for some reason. So all the patients we operated on between 10 years and 15 years failed within 5 years. So, and we had to put the PPVI within those valves or reoperate. So I think the follow-up is important. So the short term is good, but the long term for the xenografts is not very good. So, and there is some, when you put a small conduit, you have to replace it surgically, upgrade it, then put a valve inside it. So sometimes you have to do a second surgery to upgrade the conduit, because if it is a 14 or 16 inner diameter, you cannot put any valve in it, PPVI. You will create stenosis within that. So sometimes you need a second surgery to upgrade, then put a PPVI. But the follow-up is very important, and the